Hi. Okay. So I think there was some slight issue with the audio. That should be okay now. All of you ready to begin? So let's begin with Midbrain Part-2. That is part of the Neuroanatomy Basics series, right? And in this particular session, we will be talking about the rest of the portion of the midbrain that we were not able to cover yesterday. So if you recall, yesterday we had covered the section of the inferior colliculus, the section of the midbrain at the level of the inferior colliculus. Today we will be talking about section of the midbrain at the level of the superior colliculus and the defects related to the superior colliculus. Okay, so let's begin with midbrain part 2. All right, everyone's ready? Okay. So before I begin, let me quickly introduce myself. My name is Chetanya Mittal. I am currently pursuing my MBBS from AIIMS Delhi, and these are the rest of my credentials. You can go over them. As far as the subscriptions are concerned, we have two subscriptions. One is called as the Plus subscription. The other is called as the Iconic subscription. So in the Plus subscription, you get full access to Unacademy and all the courses that are available, including all the live batches and the courses. Okay, so there is no restriction on that, and that's included in the Plus subscription. In the Iconic subscription, you also get access to Prep Ladder, okay, which has recorded sessions of the most important topics arranged topic wise and subject wise. So that is very useful for your preparation, especially at the last moment. Along with that, you will get the printed notes delivered to your doorstep, and the best way to utilize them is to add whatever you are learning on Unacademy and Prep Ladder to these notes itself. Okay, that will save a lot of your time. You will not have to waste time in just copying down what is written. Instead, you will be actively learning. Okay, so these are some of the features of the special class on Unacademy. We have interactive live sessions, right? Polls, raise a hand feature. So tomorrow at 7 p.m., that is tomorrow 22nd December, tomorrow I've scheduled a MCQ session on Unacademy special class. So you can go to the link in the description, right? You will see my profile and you can follow me there, and you can also enroll for tomorrow's special class. I'll also have the link for the special class put on the Telegram channel, right? We also have a Q bank on Unacademy which has over 25,000 questions, and you already know about the result of ours during the NEET PG examination September 2021. We had a beautiful result, and this is the raise a hand feature where you can unmute yourself and interact with the educators in the live session. New feature is the Unacademy medical PG tests. So these are weekly tests that will be conducted on the Unacademy platform. Some of them are free tests, so you can participate in them. And if you go for a Plus subscription, you will get access to your tests of your particular batches. Okay? We have started new batches for FMG and NEET PG, and there is no restriction. Those who are watching FMG, they can also watch NEET PG. It's a single subscription where you can watch multiple batches, right? So don't worry about that. So if you go for a 2-year subscription plan, you're going to get 4 months free of cost. With a 1-year plan, you get 2 months free of cost, and with a 6-month plan, you get 1 month free of cost. This is provided you are using an educator referral code, that is CHETANYA10, Chetanya 10, right? So please remember to use this referral code while taking a subscription. And we have the subscription plans for Plus and Iconic, and these are the various prices. So I would recommend you go for the 1-year or the 2-year plans, and a longer plan, because it's the best way to go if you want to reduce the cost on a monthly basis. Okay, so this is how you have to purchase. Go to the Unacademy Learner application, select your goal as NEET PG. Then you can select either Plus or Iconic, select the duration of the course, and then you have to apply my referral code, that is CHETANYA10, Chetanya 10, right? So this will give you a direct 10% discount, and of course free months if you are taking a Plus subscription of 2-year, 1-year or 6 months. And try to take it on an Android device or on the desktop platform, because on iOS, instead of getting a 10% discount, you get free weeks. So it's better to take the discount by using the referral code. So let's talk about Midbrain Part 2, and today we have to talk about this section at the level of the superior colliculus. Very important section. So yesterday we had discussed the section at the level of the inferior colliculus. So what all do you remember that we had discussed yesterday? Do you remember the section that we had drawn? Did you practice it once more? Because I'll advise कि आप एक बार उसको और practice कर लोगे, so it gets more solidified, of course, है ना? So it's advantageous if you do it that way. ठीक है? So yesterday I had explained a few concepts to you regarding the inferior colliculus, and in that I had talked to you about the basic concepts of the midbrain. So if you haven't watched part 1, you can of course go ahead and watch part 1. There was a lot of explanation that was there yesterday. So I have, this is a different presentation, so I don't have that section here right now. I can insert it. Okay. So this was the diagram that we had drawn yesterday. This was the diagram that we had drawn yesterday for the inferior colliculus. So before that, I want to come back to the fact that the midbrain, it is divided into 4 parts. It is divided into 4 parts, right? So if let's say this is your midbrain, the part dorsal to the cerebral aqueduct, it is called as the tectum, where you have the colliculi, right? And the part in front of it, it is called as the cerebral peduncle, which is divided into tegmentum, substantia nigra, and the crus cerebri, right? This division, you remember, the division of the midbrain into these 4 parts is important to draw the cross section. You will be able to draw it very easily once you have an understanding of how the cross section is oriented. Okay? Now let's look at the same here. Here you have the cerebral aqueduct. Here you have the cerebral aqueduct, right? So if I make a demarcation here, anything that is present in front of it should lie in the tegmentum, and anything behind it should lie in the tectum, right? So that is the tectum, and in the tectum you will have the superior colliculi. In the tectum here at this level, okay, so this is called the section at the level of the superior colliculus or the red nucleus. Okay, I'll talk about the red nucleus. So here you have a feature called as the superior colliculus. What is its function? It is mainly useful in visual reflexes. So where are superior colliculi involved? They are involved in visual reflexes. Is that correct? Right. So that is the first thing to remember in this particular cross section. So in the gray matter, you have a very important component called as the superior colliculus. So superior colliculus, it receives afferents from the retina. It also receives afferents from the inferior colliculi, and it will integrate all this and it will give rise to the tectospinal tract, right? So tectospinal tract, what is the use of the tectospinal tract? For example, you have to understand, let's say in your vision, you see that there is a car coming very fast. Immediately you will move away. Or let's say you see a puddle of water. Okay, immediately your eye sees that there is a puddle of water. So you will try to avoid walking in that. So there is a tract that goes from the tectum, that is the superior colliculi, to the spinal cord, right? So it will control the reflex movements of the eyes as well as the movements of the body in response to visual stimulus. So superior colliculus is very important for this reflex function. Okay. Once you are done with that, let's talk about the rest of the nuclei. Remember at the level of the inferior colliculus, which was the cranial nerve nuclei that was present, you had the nucleus of the trochlear nerve. So at the level of the superior colliculi, you have the nucleus of the oculomotor nerve. Very important. You have the nucleus of the oculomotor nerve, giving rise to the third cranial nerve, oculomotor nucleus. Right? Along with oculomotor nucleus, you have another nucleus that is closely associated to it, called as the Edinger-Westphal nucleus. They haven't drawn it separately, but you can draw it like this. There's another nucleus, Edinger-Westphal nucleus. Okay, so I'll draw it in the cross section when I am telling you how to draw it. Okay, just for explanation, just understand oculomotor nerve and oculomotor nucleus. They're very important components that are present here in this ventral region. Okay. right? I have told you in the previous session also, the gray matter surrounding the aqueduct is called as periaqueductal gray, PAG, periaqueductal gray matter. It is involved in the pain modulation. It is involved in the pain modulation, right? Then there is another nucleus called as the red nucleus. Very prominent, very big structure here. You know, it's so prominent in this section that you cannot miss the red nucleus. Okay, it's very large. It's not a microscopic structure. It is almost half a centimeter in diameter. It's almost 5 millimeters in diameter, right? And the red nucleus, it receives a lot of afferents. It receives afferents from the superior cerebellar peduncle, which are coming from the cerebellum, right? It receives afferents from the basal ganglia, such as the globus pallidus, the subthalamic nucleus. It receives afferents from the cerebral cortex, and finally, all its information, it goes into a tract called as the rubrospinal tract, right? There are other tracts, other efferents also, such as the, you know, rubrothalamic tract, rubro-olivary tract, right? And then it also gives some efferents to the reticular formation. What is the role of the red nucleus? Okay, so that is the role of the rubrospinal tract. You should remember, it has an inhibitory influence on the muscle tone. Okay, so very important to remember the function of the vestibulospinal tract and rubrospinal tract. When you will be studying posture in neurophysiology, it will be significant. Okay, so rubrospinal tract, it has a inhibitory influence on the tone of the muscle. Okay, so it is related to motor movements, red nucleus. Okay, and as soon as it gives fibers, so they form the rubrospinal tract after decussation. So these decussating fibers, they are fibers of the rubrospinal tract. They are fibers of the rubrospinal tract. Then in front, remember, this was the substantia nigra. This here, this was the substantia nigra. So I'll, put it with a different color. This structure here was the substantia nigra. So this might get confused. Put it in green, right? So this structure here, this is the substantia nigra. And in front of the substantia nigra, you had crus cerebri. In front of it, you had crus cerebri. So this whole thing is the crus cerebri, right? And remember, we divided it into 6 parts. So the medial 1/6 is responsible for carrying frontopontine fibers. The middle 2/3 is responsible for carrying corticospinal and corticonuclear fibers. And the lateral 1/6 is responsible for carrying temporopontine fibers, and along with it, paritopontine and occipitopontine fibers also. Okay. So what else is left in the tegmentum? What else is left in the tegmentum? Right, remember in the midbrain you also had the mesencephalic nucleus of the trigeminal nerve that was going to be present. The lemnisci are going to be present, and you will also have the medial longitudinal fasciculus, as was present at the section of the inferior colliculi of the midbrain. Is that clear to each and every one of you? No doubts? Please let me know, guys. If you have any doubts at all, please let me know. Everything clear so far? Can I move ahead? Right. So after this, let's practice drawing this, how to draw it. So let's draw the section at the level of the superior colliculus, or it can also be called the section at the level of the red nucleus. Clear? So whichever you prefer to call it, you can draw it accordingly. Okay. So first of all, what structure will we draw? First of all, what structure will we draw? So you should always start by drawing the basic outline, of course. So the outline here is very simple, nothing complicated about the outline. Just that you have to be accurate in drawing it. Right? So here you can draw it like this. Right? So that is more or less the outline. Now I am paying less stress to substantia nigra and the crus cerebri because it's more or less very simple to draw. So this is the substantia nigra. I'm not even going to label it, but you should know that what I have drawn here, this is the substantia nigra. In front of it you have the crus cerebri. Please remember to mention the lateral 1/6 carries fibers of the temporopontine, peritopontine and occipitopontine. The medial 1/6 carries fibers of the frontopontine, right? Then in the center you have corticospinal and corticonuclear fibers, where the fibers that are most medial are those of the head. Then you have fibers of the arm. Then you have fibers of the leg. Right? Very important. So this is the crus cerebri and the substantia nigra. I am not making any additional labelings. Okay. So the important thing here to draw is the tectum and the tegmentum. So for tectum and tegmentum, first of all, you will draw the cerebral aqueduct. This is the cerebral aqueduct. I'm not making any labelings. Surrounding it, you will have gray matter. And this is actually the periaqueductal gray matter. Periaqueductal gray matter. You can even make it larger. Periaqueductal gray matter surrounding the cerebral aqueduct. Clear? Right. Now once you have drawn that, it's very important. This is the section at the level of the superior colliculus. So you will draw the superior colliculus. Right? And that is part of the tectum. So I'm removing the diagram on this side slightly more prominent. Right? The tectum. Okay. So this part here till here, this was the tectum. Now remember the superior colliculus, it is connected to the lateral geniculate body. So you can even show that lateral geniculate body responsible for vision, and this connection is called as the superior brachium. Okay, so just for, I had not shown the inferior brachium very properly when we were drawing the section at the level of the inferior colliculus, but in this section I am showing you superior colliculus, superior brachium and the lateral geniculate body. Alright. Now we will draw two very important structures. One here is called as the oculomotor nucleus. And on top of it you have another nucleus associated with it like this. That is called as the Edinger-Westphal nucleus. That is the parasympathetic nucleus of the oculomotor. So I'm writing Edinger-Westphal nucleus, EW nucleus. and this is the oculomotor nucleus, and together they will give rise to the oculomotor nerve. Together they will give rise to the oculomotor nerve, which will pass between the cerebral peduncles. Which will pass in between the cerebral peduncles. Okay? When I teach you neuroanatomy, I will tell you one more important point here, but I am not mentioning it because in the diagram it will make things complicated. Okay? In front of the superior colliculus, you have another nucleus here called as the pretectal nucleus. If you want to draw, you can draw. Pretectal nucleus. Okay. What is the function of pretectal nucleus? Pretectal nucleus, it is going to receive afferents from the optic tract, and it is going to give efferents to the Edinger-Westphal nucleus. Okay, and it is very important for the light reflex. When I teach you in physiology about light reflex and consensual light reflex, that is direct and indirect light reflex, you will understand what is its importance. And if there is a damage to this nucleus, the pupil is called as the Argyll-Robertson pupil, in which the light reflex is lost but accommodation reflex is reserved. So pretectal nucleus is present superolateral to the superior colliculus. Okay, very important. It's more important in neurophysiology. At this point, I just don't want you to miss out on any term. Okay, so that tomorrow if you are told that अच्छा pretectal nucleus लिखा आ गया है पेपर में, you don't get confused कि यार pretectal nucleus कौन से लेवल पे कहाँ होता था, है ना? So if it's there in the cross section, you will have a visual memory कि okay, in front of the superior colliculus there was something, and that was the pretectal nucleus. Okay. On the sides you have the mesencephalic nucleus of the trigeminal. Here you have the mesencephalic nucleus of the trigeminal. ठीक है, mesencephalic nucleus of the trigeminal. Now we can draw two very important things. Those are called as the red nucleus. Can we draw the red nucleus? Right. So let's draw the red nucleus, guys. Large structures. Red nuclei. Okay. So I don't think I even need to mention that this is called as the red nucleus. Okay. Now here in this particular diagram, the decussation of the rubrospinal tract was shown to you, remember? But that is not the only decussation that happens. There are actually two decussations that happen. Okay, so let me show you that in a way that you will understand automatically that what decussations am I talking about. Okay, one decussation is this. The other decussation, I'll show it in orange. Now make out what are the two decussations. So this one will obviously be called, so both decussations, they are occurring in the tegmentum, right? So this is called as the dorsal tegmental decussation. Dorsal tegmental decussation. And this one here, right here, this is called as the ventral tegmental decussation. This is called as the ventral tegmental decussation, right? So dorsal and ventral tegmental decussation, they are shown to you. Dorsal and ventral tegmental decussation. Okay. Now you will automatically understand due to the colors. Due to the colors, you should be able to understand what is the ventral tegmental decussation and dorsal tegmental decussation. So it is the crossing over of which tracts the descending axons from the red nuclei to form the rubrospinal tracts, Okay. And what about the dorsal tegmental decussation? It is the crossing over of axons from the superior colliculus to form the tectospinal tract. It is crossing over of fibers from the superior colliculus, the descending axons from the superior colliculus to form the tectospinal tracts. Ultra important to know. And it's very logical, just you can make it out very easily. Okay, the ventral tegmental decussation is very close to the red nucleus, and this one is related more to the posterior side, so it will be related to the crossing over of the superior colliculi fibers. Okay. One more structure that I will be drawing in almost every diagram here. That was, if you remember, that was the reticular formation that you can draw. Reticular formation. On the sides, you can also draw the lemnisci. Okay, you won't have a lateral lemnisci now. You will be only showing the spinal, trigeminal, and the medial lemniscus. Okay, so it's up to you. If you want to show, you can show it in a single diagram, or you can draw medial lemniscus, trigeminal, and spinal. So I can mention that these are the three lemnisci. Okay, no lateral lemnisci. This is the spinal lemnisci, trigeminal lemnisci, and medial lemnisci. Do not draw the lateral lemnisci. That's already over here. By the time you reach here, it no longer exists. Okay, that ended at the level of the inferior colliculus. Okay, and one more thing that we always used to draw here, median longitudinal bundle, right? MLF, median longitudinal bundle, median longitudinal fasciculus, you can draw it. So this is the medial longitudinal bundle. Okay, that brings us to an end of this diagram. Now, along with this, there is one more point you should remember, that rubrospinal tract, it has an inhibitory influence on muscle tone. It is inhibitory to the muscle. It has an inhibitory influence on the muscle tone. Okay, so for example, if I cut the rubrospinal tracts, what will happen? There will be spasticity because the muscle tone will be increased. If I cut over the rubrospinal tracts, what will happen? The inhibitory influence is gone, so muscle tone will be increased. So please remember, rubrospinal tract, it is inhibitory to the muscle tone. It is inhibitory to the muscle tone. Very important for you to remember. Okay. Then I had one point about the pretectal nucleus. You can write that. So see what happens. This is the optic nerve. This is the optic nerve. So it gives some fibers. These fibers, they are going to go to the pretectal nucleus. They are going to go to the pretectal nucleus. What the pretectal nucleus does is, it communicates the information about light to the Edinger-Westphal nucleus, Remember, it gives parasympathetic nervous system fibers, PSNS. So it causes constriction of the pupil. Okay. What is light reflex? Light reflex refers to the constriction of the pupil when light is shown into one eye. So direct light reflex means I shine light on the left eye, the pupil of the left eye is going to constrict. What is consensual or indirect light reflex? I will shine light to the left eye, the eye of the right side is going to constrict. The reason is the innervation is bilateral. There is bilaterality. So information from one optic tract goes to both pretectal nuclei, both left and right side. So pretectal nucleus, if it is damaged, what will happen? There is a condition known as Argyll-Robertson pupil, in which what happens? light reflex is lost, but accommodation reflex is preserved. So AR, right, accommodation reflex preserved, ARP, accommodation reflex preserved, ARP, right? But light reflex is lost. Why? Because pretectal nucleus is damaged. Why is accommodation reflex preserved? Because Edinger Westphal nucleus is still intact and the accommodation reflex is not mediated by the pretectal nucleus. Very important as a neuroanatomy clinical correlate. Okay, so I might also mention it there. So this is about the section at the level of the superior colliculus. Anything else that you guys wish to ask me? So decussation of tectospinal tracts, dorsal tegmental decussation, decussation of rubrospinal tracts, ventral tegmental decussation. Right, so since this is the last lecture of the various parts of the brainstem, I will also write one small short note about the medial longitudinal fasciculus or the medial longitudinal bundle. Okay, so it is written as medial longitudinal bundle. Okay. So what are the constituents? Main constituent, they are the fibers from the left and the right. Medial vestibular nuclei. Okay, vestibular nuclei. So very important function will be related to balance. Okay, and these fibers, they will go up till the, there's a nucleus called as the interstitial nucleus of Cajal, right? That is present at the upper end of the aqueduct. So these fibers, they're going to go till there. Okay, so they are extending right from the cervical segments of the spinal cord till the interstitial nucleus of Cajal. So they are present throughout the brainstem. So any lesion in the brainstem, you can have damage to the medial longitudinal bundle. The importance of these cranial nerve nuclei are that they connect. They are going to connect cranial nerve nuclei 3, 4, 6, right? Because they connect cranial nerve nuclei 3, 4, 6, they are responsible for integration of movements of the eye. Movements of the eye, right? They also connect these two cranial nerve nuclei 8 and spinal part of the accessory, right? That is why they are also responsible for movements of the neck, right? Because remember, this supplies the trapezoid muscle, right, which is responsible for neck movements, and this is responsible for maintenance of equilibrium, right? So that is the function of medial longitudinal bundle. Last topic, blood supply of the midbrain. Blood supply of the midbrain. Can you guys tell me? So main artery will be the basilar artery, the branches of the basilar artery which are going to supply the pons. So they are also supplying here. So branches of basilar artery. Apart from that, if you remember the diagram, right, the basilar artery divides into two arteries, right? First, it gives the superior cerebellar artery. It gives the superior cerebellar artery. Then finally, it terminates in the posterior cerebral artery. Okay? And in between these two arteries, you had the oculomotor and the trochlear nerves arising, right? So if the oculomotor nerve, it is arising from here, that means that the level at this, that this is the level of the superior colliculus. This is the level of the superior colliculus. So that means that both these arteries, the posterior cerebral artery and the superior cerebellar artery, right, both these two arteries will also supply. So branches of basilar artery along with posterior cerebral artery, superior cerebellar artery, which supplies the cerebellum, superior cerebellar artery, and also to some extent the artery that comes here, that is the posterior communicating artery. So posterior communicating artery, and also, you know, from the anterior side you will also have some supply from the anterior choroidal. So it's very easy to visualize basilar artery, PCA, SCA, and this one. So at least this much you can remember regarding the blood supply, even if you forget about anterior choroidal. Okay. So now there are two important things that you should know in this particular chapter. Correct. So 2-3 more things, you know, and I'm not going to write them down, but I just want you to read them from the textbook. Read once about the connections of the red nucleus. Read once about the connections of the medial longitudinal bundle, and also once read about the connections of the inferior colliculus. ठीक है? See, the Malhar party at AIIMS, that is actually a party of the, you know, Society of Young Scientists, that is basically related to the BSc students. So it was not an MBBS party. So I absolutely have no idea how that party was. Right. So guys, let's move ahead. And let's talk about the clinical correlates. Clinical Okay, so what are the lesions that you need to discuss here? What are the some of the lesions that you need to discuss here? So you need to discuss 3 things. Okay, you need to discuss 3 things: Weber syndrome, BENEDIKT syndrome, and PARINAUD syndrome. Let me repeat: Weber syndrome, BENEDIKT syndrome. The third one, you know, you all might or might not be aware: PARINAUD syndrome. Okay. So for Weber and BENEDIKT, you will find beautiful diagrams. PARINAUD, I will explain. Don't worry. PARINAUD, I will explain. Okay. And one more that we have already covered, but you know, just for the sake of completion, I will write it. That has to be discussed here. That was Argyll Robertson pupil. Okay. So 4 things in clinical correlates. ठीक है, शुरू करें. So first let's discuss the Weber syndrome. Let's first discuss the Weber syndrome. Okay, so it's also written sometimes as Sturge-Weber syndrome. That's actually a different thing. Okay, so please don't get confused. Let's think about Weber syndrome. Okay, so Sturge-Weber is a different thing. Weber is a different thing. So right now I am talking about the Weber syndrome, which is related to the stroke of the midbrain. It is related to the stroke of the midbrain. Okay, a basal infarction. Okay, and in that what is going to happen? Just imagine that this is the section of the midbrain. This is the section of the midbrain, right? At the level of the superior colliculus. So this was the third cranial nerve. It was emerging from here. So what is lost basically is this region. This is damaged. So there is damage to the crus cerebri and there is damage to the third cranial nerve. There is damage to the crus cerebri and there is damage to the third cranial nerve. So we will take a better diagram than this. Not very satisfied with this diagram. You can find a better diagram. Let's take a diagram where Weber and BENEDIKT, they're both shown together. Okay. So that diagram you will find here. Okay, so this is the diagram. In this, look at the area damaged. Look at the area damaged in 1, right? Look at the lesion 1. Okay, this shaded part. Let me reshade it so that you guys don't have any confusion. This is the damage. Okay, so there are two main things that are damaged. And that will produce symptoms. You also have damage to the frontopontine fibers, I know, but mainly think about damage to the corticospinal tract. And since decussation has not happened, you will have contralateral hemiplegia. So any lesion above the medullary decussation, you will have contralateral hemiplegia, right? So if the right side is affected, you will have damage to the left side and vice versa. Second, because oculomotor nerve is damaged, right? And oculomotor nerve, you all know it is a lower motor neuron. Okay, so you will have ipsilateral lower motor neuron palsy. Ipsilateral, right? Why ipsilateral? Because now you are at the lower level of the lower motor neuron after the decussation. Okay, it's not the corticobulbar tract, so it's going to be ipsilateral and lower motor neuron palsy of the oculomotor. So oculomotor nerve supplies all the muscles except lateral rectus and superior oblique. So all the muscles, they are going to be involved. So because lateral rectus is intact, you will have lateral squint. Okay, it will appear that the person is always looking towards the lateral side. Okay, both eyes whichever side is damaged, on that side the eye will be rotated towards this side. The eye will be rotated towards left side. So the person will appear like this. Are you able to see? So this is lateral squint. So this eye will be rotated and this eye is looking forward. So that is lateral squint of this side, means there is a lesion on this side. There is a lesion on this side at the level of the midbrain. Okay? So lateral squint. Did you understand why there is lateral squint? Because medial rectus is damaged, lateral rectus is intact. So medial rectus is not able to function. So lateral rectus will pull the eye towards the lateral side. Lateral squint. Okay? Do you want me to put an image of a lateral squint, because that is going to be characteristic if you have an image based question for a lateral squint? They might very frequently they will give you a question, and lateral squint is very commonly, you can see it in people. Okay, it's not that it's a rare entity. Okay, दिख जाती है lateral squint. So you can see this eye, it is, so you see here you have the lateral rectus. Here you have the medial rectus and here you have the lateral rectus. So if I damage this medial rectus, the eye will be pulled outward, right? So this is lateral squint. Next, let's talk about the BENEDIKT's lesion. BENEDIKT. Okay. Again, we will put this diagram. So you can make out what is the BENEDIKT's lesion. There is damage behind the substantia nigra. It's mainly a tegmental damage. This region is damaged. Okay, so you will have damage to the red nucleus, medial lemniscus and oculomotor nerve. Okay, right? So most of the tegmentum is damaged. Three things important. Okay, because the medial lemniscus is gone. Remember, medial lemniscus carries fibers from the dorsal column pathway. So loss of proprioception. Important. Loss of proprioception. This will be contralateral because decussation has already happened. Okay. Second, You will have injury to the oculomotor nerve. Same as Weber's, right? Same as Weber's. This lesion will be same, lower motor lateral squint. Third thing is, due to damage to the red nucleus, you have a very important thing that happens. Because red nucleus is damaged, I told you red nucleus is responsible for inhibition of muscle tone. Now, because muscle tone is hyperactive, you will have tremors and twitching of the opposite side. The reason is, again, decussation has not happened. Decussation was happening in this region, right? So the nucleus is damaged. That is why it affects the contralateral rubrospinal tract. The left red nucleus gives rise to the right rubrospinal tract. So that is why you will have tremors and twitching of the opposite side. Okay? Opposite side. So did you understand Benedikt's and Weber's? Very important. Difference between Weber's and Benedikt's. Very, very important. Last is PARINAUD syndrome. Okay. Now, PARINAUD syndrome, it is again important. For that, I will have to explain some anatomy that I haven't told you about. So, in the superior colliculus, what happens is that if you have the superior colliculi, if these are the superior colliculi here behind, there is posterior commissure. This is the posterior commissure. It connects the both superior colliculi. This is the posterior commissure. So this gets damaged. Now think of it in this way, that you are basically damaged the communication of the both superior colliculi. So you are essentially affecting the functions of the superior colliculi. Now superior colliculi, it is important for coordination between the two eyes, right? Because of that, you have weakness of the upward gaze. You are not able to look upward very effectively. Weakness of the upward gaze. So it's called as upward gaze palsy. Upward gaze palsy. And you also have vertical nystagmus. The details of nystagmus I'm not going, because then that will become a whole separate topic right now. Okay. So that is where we should end. Argyll-Robertson pupil, I've already told you, there is damage to the pretectal nucleus, because of which light reflexes gone, whereas accommodation reflex, which is mediated by Edinger-Westphal nucleus without the involvement of pretectal nucleus, it is preserved. Okay, and that's a very good mnemonic in itself. Accommodation reflex is preserved. Argyll-Robertson pupil. ARP, right? Easy. So hopefully that brings us to an end on this session. No doubts to anyone? Anyone has any doubts, you guys can please tell them right now. If you guys have any doubts, please feel to tell them to me so that we can discuss. Any doubts? Any doubts, guys? So there's damage to the nuclei of the posterior commissure, right? Superior colliculus damage. Shall we end the session? Okay. Right. Thank you so much, guys. Thank you so much for listening. I hope you guys liked the session and were able to understand each and everything. Please remember to drop a comment once this session ends. Share it with all your friends. Ask them to study neuroanatomy from this very channel. For the simplicity and for best understanding, I've created a playlist for the neuroanatomy sessions so that you can easily watch them. Thank you so much, guys, for watching. Please remember to subscribe to Unacademy Future Doctors, and very soon you can also download the PDF, which is available on the Telegram channel. The link for the Telegram channel is there in the description. Okay? It's almost by the same name. Thank you so much. And that brings us to an end on the sessions on brainstem. Now, there might be some short videos that I make for you guys to watch, and then we will move on to cerebellum. Okay? Tomorrow, I am just going to quickly remind you that we have a special class on Unacademy. Okay? So if you haven't already downloaded the Unacademy Learning app, please do so. And you can join me for tomorrow's revision session. Okay? On the Unacademy platform. All you have to do is go to the link in the description, the link for my profile, and from there you can enroll for the neuroanatomy revision session. Okay, it starts tomorrow at 7 p.m. It is at 7 p.m. Right? So tomorrow 7 p.m. See you guys. Okay, thank you. Bye bye. Take care. Right, guys? Okay, bye bye. So if any doubts are there, you can always clear it up in the next session. And some pending videos from my side are related to the blood supply of the spinal cord. So I'll also be uploading them shortly. Right? Thank you, guys. Bye bye. Take care.